AVR, what is the rhythm? You should start like fighting to give the answer here now. I'm starting to give you a little ones now where you have to think a little bit more. Ignore the ECG. Look at the rhythm strip. Irregularly irregular. It's chaotic. It does not have a pattern to it. It's atrial fibrillation. Okay? Sometimes it can be a bit trickier because of the fact that it's fast. So be careful for that one. It's irregular, but it's very quick. And you think, it's not AF, whatever. Then what you do is you take your little paper out, you mark the dots, there's a QRS, okay, you move it on, and then you quickly realize, it is still atrial fibrillation. Sometimes you get this situation. You see, this is what confuses people. They look at the ECG, V1, V2. Is this a flutter wave? But I can see P waves here. Irregular is AF. That's it. You will not go wrong if you do that. 99% of the time, you will be right. Because flutter is such a classical rhythm to be able to see on the ECG. You see, you can look at any of the leads here. Remember, I always teach, whatever's happening down here is happening up there, right? So if I'm seeing a P wave here, I must see the P wave here. If I'm seeing a P wave here, I must see it there. If I'm seeing, look at this for example. I may be seeing something over here, I don't see it over here. But these are running at the same time. Your ECG is supposed to be calibrated in that way. You'll see the QRSs are happening at exactly the same time. So use that fact. I see, look at those beautiful P waves. This must be a flutter. So where are the flutter waves down here? No flutter waves. Atrial fibrillation. Whatever's happening here is happening there, is happening there, is happening there. It's common sense. You do not have to struggle with this, but people do. People do struggle. So we spoke about irregular heart rhythms. Now I'm going to speak to you about regularly irregular heart rhythms, because that's the one which throws you. Is this patient in sinus rhythm, yes or no? Okay, I like that. It was quick. And why? Because you looked at the P wave in 2 and 3 in AVF, and regardless of what the rest of the QRS complexes are doing, you're only interested in that P wave. And you looked up here in AVF, and it was negative, sinus rhythm, end of the story. This patient is in sinus rhythm. But there are some other stuff going on down here. Now you have to decide what are those other stuff. This is sinus rhythm, right? There. Then you see another beat coming through earlier. This beat looks exactly the same as the beat that came before it. Are we agreed? It came earlier, so it's a premature beat. What we need to decide is it the premature beat which is coming from the atrium, or is it the premature beat which is coming from the ventricle? What's the consensus over here? Yeah. So is it broad or not? Yeah, the reason is the whole QR, all of them appear broadish to me, but it's certainly not more broad than the one that came before it. So I'm going to say that this is most likely an atrial ectopic. It's a supraventricular ectopic. Huh? Remember that first ECG I showed you? A ventricular ectopic is broad and bizarre. You can't confuse it with anything else. This one you can clearly say, but it looks exactly like the same before. In other words, what it's doing is it is traversing the same electrical pathway as the one before it. Okay. If it's a ventricular ectopic, it's coming from within the ventricle, outside of the His-Purkinje system. So because it's outside of that narrow insulated bits of cabling, it will tend to be much broader. Okay, so this is regularly irregular because why? You had an atrial ectopic, you had probably a sinus beat in, an atrial ectopic. But this is not atrial fibrillation because I can see a clear relationship. Look at this, between the P wave and the QRS. P wave, QRS, P wave, QRS. Okay, it's very different from any of the other ones that we've seen. Nowhere there do you have very nice P wave activity, and P wave activity which you can map throughout the entire ECG. It's not a secret. There's a P there, I'm not sure, I look there. There's a P there. I'm not sure, I look there, there's a P there. I'm not sure, I look there, there's a P there. This is sinus rhythm with atrial ectopy. This is an example of a regularly irregular rhythm. Okay. All right, so we have sinus with ectopy. Okay, so just to re-emphasize again, Is this sinus rhythm? Okay. And is there something weird on the ECG? Okay, fine. What is it? It's a ventricular ectopic beat. Why? It is early, but now you can see the difference. It doesn't look anything like the QRS which precedes it. Sinus rhythm with ventricular ectopics. Okay, fine. Now we come to atrial flutter. Before we get to atrial flutter, one of the companies has asked us just to comment quickly on atrial fibrillation management. And I think it is important. It's very important. All right, so I'm going to put up a case study here for you quickly, and I'm going to be very interested to know what your feelings will be. Let's try this one. And it's handy because it's practical. We were speaking about atrial fibrillation and diagnosing the ECG, so let's just give you a little bit more information. Atrial fibrillation case study, right. Yeah, this is basically forwarded from the manufacturers of Pradaxa, which you would have heard about, I'm sure, which is the new substitute for warfarin in many of the guidelines, as is some of the other agents which are available, like rivaroxaban, which is also called Xarelto. But this is specifically Pradaxa. All right, fine. So let's just quickly think. You've got a 66-year-old man. He presents to your consulting room complaining of episodic palpitations, of dyspnea and syncope. His comorbidities are that he is only hypertensive. All right. So what's the next thing you do? Which tool would you employ to confirm a diagnosis? An ECG. Great, great. Fine. That's why you're here today. We can do the ECG. Fine. There's the ECG. The ECG shows what a regular rhythm looks like. It's a normal heart rate, regular rhythm. There's some P waves, steady baseline. In contrast to atrial fibrillation, where you have an irregular rhythm. Forget about the whole no P wave thing. That just confuses everybody. And obviously, AF can be a bit faster, and you have atrial fibrillation with a rapid ventricular response. So you did the initial diagnosis, and you did the ECG, and the ECG showed that. All right? So your next step, you could probably consider asking someone, can you do a Holter? Because I'm a bit concerned this guy's having palpitations. I'm not sure whether I need to have a diary, and he needs to write down when he's feeling what, and I need to see on paper what there is, okay? So today, as you're aware, you can't do Holters and stuff all the time on everybody. So if I have patients who come and refer to me with SVT, and I don't know what's wrong with them, and I'm convinced they're having a palpitation, there's a little device which is called a link recorder, which I slip underneath the skin. So it takes about 10 seconds, 10, 15 seconds to put it in. And it lasts for about 3 years, and it's got an activator that the patient keeps outside. So it's very useful for patients who are having palpitations, but infrequently. Okay, so I just want to bring that to your attention because I find it really an indispensable part of my normal practice. Because I see so many of these patients that have had syncope, that have palpitations, have had so many Holters, etc. We put that in, you can monitor them for up to 3 years, but most importantly, with the activator, they can actually click when they're having the symptoms so I can see what it is they're feeling. And the activator records from at least 2 minutes before, before they started, before their symptom complaint. So an implantable loop recorder is really an indispensable part of one's daily practice. But for people who are having palpitations all the time, I had a lady yesterday, she said, I'm getting it almost every day. Why on earth would I want to put in a loop recorder? Just put the Holter on, and let's see, and you come back. So a Holter is a portable ECG device for continuous monitoring, short time period, typically 24 hours, useful for detecting symptomatic AF, evaluating paroxysmal AF, etc. Associated symptoms with heart rhythm disturbance, and assessing the treatment response afterward. So we make a diagnosis of paroxysmal atrial fibrillation. Keep in mind, he is 66 years old, and he has hypertension. Right. Next thing. So the types of atrial fibrillation you see these days, and AF is a huge part of our work. There is like an epidemic of atrial fibrillation because it is so common. It is a terribly debilitating disease, and it is an extremely complex disease to treat. Extremely complex. And as a consequence, the majority of AF fibrillation, AF procedures I get referred from are from general cardiologists who have been having difficulty getting the AF under control. So how do you characterize AF? Paroxysmal AF usually is AF less than 48 hours. Persistent AF means that the AF has been present for more than 7 days or has required a cardioversion to return to normal rhythm. Long-standing persistent AF has been present for more than a year. And permanent AF is where we've accepted the AF. Take your warfarin, take your beta blocker, let's just continue like this. There's no point for me to try to do any kind of heroics to get the heart back into normal rhythm. What are the consequences of AF? The consequences are obviously that you end up with thrombus or clot in the high-risk patient, those who have a CHADS-VASc score, which I'm sure you're all familiar with now. The atria are fibrillating, so there's turbulent flow, clot is formed. This goes into the left ventricle via the mitral valve, and from there it's ejected into the aorta. And the first vessels coming out of the aorta are obviously the neck ones going up to the brain. So stroke is a huge, huge problem, unfortunately. You end up with blood clots and thrombosis, which embolize, they lodge in the brain, and the patient experiences a stroke. All right? So here in this particular setting, you have a tiny clot, and essentially you are blocking off the middle cerebral artery, the M1 segment, leading to a middle cerebral artery infarct. Fine. Now, important to note that stroke risk persists in asymptomatic paroxysmal AF. So the fact that the patient's not feeling AF, or the fact that they're only having short runs of AF, doesn't mean they're not at risk for stroke. The patients who are at risk for stroke are in particular this group. It's not the group where they come in and they're in AF all the time. Everybody knows they have to be on warfarin. It's these guys over here. Okay? So it's intermittent AF or sustained AF. It doesn't really matter. If you're looking at the CHADS-VASc score, they will end up with a similar risk for stroke. And that is something I've realized people do not have a good grasp on. Just because you're going in and out of AF doesn't mean you have a different risk profile to someone who is in AF all the time. All right? Very, very important point to understand. The stroke risk with asymptomatic or paroxysmal AF is comparable to that in patients with permanent atrial fibrillation. How do you manage these patients, seeing that we're moving off AF now? It's either going to be rhythm control or rate control. Rhythm control means you refer them to me. I need to ablate them into sinus rhythm. Okay? Rate control means you control it either with medication, or alternatively, I cannot get on top of them with medication, and then I put in a pacemaker and I ablate the AV node and get control of the ventricle. The way things were done for the last 100 years before we could do selective atrial ablation for the last decade. And then, to me, the most important part is the prevention of thromboembolism. If I ever give talks on atrial fibrillation, and this is not infrequent at all, I start off with that. The main aim of this talk, the main aim and the goal of this talk, if you take nothing else home with you, is to protect the brain. Okay? It's all about protection of the brain. Right, so let's come to anticoagulation. Whether you have paroxysmal atrial fibrillation or persistent atrial fibrillation, you still need anticoagulation depending on what your risk factor score is. If you have congestive heart failure, if you're hypertensive, if you are age above 64, if you're diabetic, if you've had a prior stroke, if you're a vasculopath, etc. If you're a female and above 75, those are major risk factors, okay? You require lifelong anticoagulation regardless of what we were able to do with ablation therapy. That does not affect the risk of the patient to take stroke, to have a stroke, okay? So, to prevent the stroke, you anticoagulate the blood, you thin the blood, and the major trade-off is always the whole stroke prevention versus bleeding, okay? So how do you evaluate the risk of stroke? How do you evaluate the risk of bleed? All of this is available. All of this is available to you. And it's important for you to know. So to determine which patients will require anticoagulation, those are the things. Every one of these count 1 or 2, and then you add up. Depending on which guideline you're currently using, the Europeans have been so strict that they are anticoagulating everyone with a CHAD score of 1 and above. Okay? So the Americans say 2 and above, Europeans 1 and above. But I think most people are now settling for that whole thing of 1. Okay. And then on the other hand, you have the has bled score. And the Hasbled score is your risk for bleeding. So you have something to help you to determine, should I put this person on anticoagulation, should I don't? Use these scores, you know, there are apps for it, you can Google it, so, but yeah, I think Pudding will be happy to make it available to all of you, okay? And those are the kind of little risk stratification tools you use to determine the risk of stroke and the risk of bleeding, okay? The fact that the high Hasbled count is present does not eliminate the use of oral anticoagulation. Why? Because often you can treat the hypertension, etc. You can deal with the fact that the INRs are all over the place. You can remove drugs or alcohol. So this is just a starting point. So in other words, you can optimize that, and then you can put the patient onto the anticoagulant because they no longer fall in a Hasbled criteria of 3 or more. The treatments for stroke prevention in atrial fibrillation. Now, the most recent guidelines have removed the following drugs for the treatment of atrial fibrillation. You go to any guideline and someone comes to you with AF, you are not allowed to give them Dispirin. You are not allowed to give them clopidogrel. They have been removed from the guidelines. Okay? They are useless for the prevention of stroke. All right? Those are the things, obviously, that those are your options, but the guidelines have now removed Dispirin and clopidogrel. They are inferior and they are not the standard of care. The drugs that you use for anticoagulation are your old buddies, warfarin, which we are familiar with, which works well. If the patient has got good INRs and they're happy on it, you leave them on it. I don't have a major issue with that. I have thousands of people on warfarin, and I love warfarin because it means I can do my procedure on uninterrupted warfarin. We do not stop procedures, ablations for INRs less than 4. The issue with the newer agents are that I have to stop them because until now there is no antidote available. So it means prior to the procedure that at least for a day or two possibly the patient may have no anticoagulation because I have to be safe when we're working to not have the patient having a complication that I cannot treat. So the newer agents are the Bigatran and the Rivaroxaban. They belong to the same class of novel oral anticoagulant. They are now the current standard of care recommended by ESC guidelines. In other words, warfarin's always been around, and now these new chaps are on the block. All right. Limitations of warfarin. Make no mistake, it's not the easiest drug to take. It's got its issues, right? Unpredictable response, narrow therapeutic window, routine monitoring, slow onset and offset of action, drug interactions, resistance, frequent dose adjustments. Yeah, make no mistake, it's not an easy drug to take. All right? The difference between the newer agents, if you look at the two of them, the one is a thrombin inhibitor, direct thrombin inhibitor, the only oral one of its kind. The other one is a factor Xa inhibitor. The Bigatran you take twice a day. This one you take once a day. The half-life, yeah, kind of similar-ish. Renal clearance, so predominantly through kidney with the Bigatran. So you must know what the U&E and the creatinine clearance is before you cannot put the patient on Pradaxa if you don't know what the creatinine is, okay? You leave yourself open to all kinds of problems. And this has got to do with the kind of drug interactions that the patient may have. So, in the end, really, atrial fibrillation, you say it's valvular AF. Valvular AF means the patient's got a mitral valve prosthesis in, or the patient's got mitral stenosis. Those patients must get warfarin. There is no indication for them to get any other drug. If somebody has got rheumatic valvular heart disease and they've got AF, the only drug you can give them is warfarin. Okay? For people who do not have that, non-valvular AF, and they're less than 65 years old, okay, you can decide to not give them anything because they've got no risk factors. Their CHADS is 0, so you give them nothing. In the next case, you have a patient with a CHADS risk score of 0, 1, or greater than 2. CHADS score of 0, nothing. Of 1, generally you will say oral anticoagulant therapy. So most people would now say they have a CHADS score of 1. So you have got this guy, he's 66-year-old, he's hypertensive, he must get an anticoagulant. You assess the bleeding risk. And depending on that, if the bleeding risk is high or low, you can decide to give either the NOACs or the vitamin K antagonists. Okay. It's important to note that with the Bigatran, there is a reduced risk of intercerebral bleeding. So the newer drugs, it's a class effect. None of them cause you to have intercerebral bleeds as much as warfarin does. That's a fact. However, the newer agents also have their own issues. Some of them cause a higher incidence of GIT bleeding, okay? Some people say, but okay, it's not such a bad thing, you know, GIT bleeding, I can manage. I can manage a GIT bleed. Intracerebral bleed, they're often fatal. So that's one way of approaching or looking at it. So the RELY study, which introduced the bigatran, in the end really showed that a dose of 150 milligram BD was actually superior, okay, to warfarin. So the only drug which has been shown to be superior to warfarin at that dose. All of the rest have proven non-inferiority. In other words, they're very similar. The major bleeding rates, lowest is actually with the lower dose of the 110, but the default dose for Pradaxa is 150 and not 110. Okay. So if you look at the two, you'll see that, that in stroke, ischemic stroke and hemorrhagic stroke, it's really reduced by 150 milligram dose, okay? And that the major bleeds, okay, were with a higher dose were actually considered to be non-inferior, and these were yeah, in terms of the lower dose, a little bit less significant. So, yeah, blah, 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 blah. Then they did a whole FDA Medicare analysis report where they actually looked at all the patients in the RELY study, and essentially they had continued following up these patients in the real world, following up the same stuff. What, you know, what dose were you taking? What did you have an ischemic stroke during that time? This went on now for another 4, 5, 6 years after the study was stopped. They still continued because maybe they thought that the results they had seen in the study were because the patients were so closely followed up. So what happens when you release them out of the study? Follow them up for it. This is the, so Medicare did their own, the FDA Medicare in the States, they did their own study and follow up of these patients. Intracranial hemorrhage, major bleeding, GI bleeding, MI, mortality. And if you look at the two groups of slides, that the Medicare study and the RELY study, the results were almost identical. What was happening in the real world, what was happening in the study. This statistical phenomenon, I'm told, is called replication. Okay, that if you can show in the real world what is actually happening within the study. So it's a very strong statistical protagonist for the use of this agent, you know, that it wasn't only in the study that the benefits were shown, but real world, and you talked in a huge amount of patients in the Medicare. So in the end, the 150 BD is the recommended dose, except in patients taking verapamil, those who have a high bleeding risk on your Hasbler score, and patients over the age of 80, you will normally give 150 BD. Okay? For the rest, you give 110. There is no significant increase in major bleeds with decreased renal function, except when you start getting kind of more dialysis values, when your clearance drops to below 30, and then the drug is contraindicated. So if the patient's got risk factors for stroke, you look at the clearance. If it's less than 30, you can't give the drug. If it's between 30 and 50, you will then decide on the bleeding risk. If the bleeding risk is high, you go to the 110. Obviously, in a normal creatinine clearance, there you will just look at the patient's age. Above the age of 80, they get normally the 110 with a high bleeding risk. But this is made available to you by Boehringer, these algorithms. Okay, so this is just an example about how things are going to be changing now in terms of the anticoagulation for atrial fibrillation. It's a very important thing because must I put the patient onto warfarin? Must I put him onto these newer agents? The newer agents means I must have the creatinine clearance checked. I must know what the patient's Hasbler score is, etc., etc. But the newer agents are supposed to be safer because there's decreased risk of intracranial bleed. There's a slightly higher risk of GIT bleed, etc., etc. So the choice is between yourself and your patient. My advantage is get to know one of the drugs well. And then, you know, from there you can then decide how you're going to play it. You're probably going to ask me what the issues are in terms of reimbursement for these agents. And the issues are big because the agents are still very expensive and warfarin is still dirt cheap and it is effective. So, you know, the only time really they are giving it out easily without co-payments is if people have had issues on warfarin before, let's say allergies or a significant bleed. And then they would also consider it in patients where the patient is living more than 150 kilometers away from the closest pathologist, for example. So they can't have their blood tested regularly. So that's just a case study in terms of the use of the drug Pradaxa, which, as you know, is the bigatran and is the only oral thrombin inhibitor which has now been registered and available all over the world as anticoagulation for AF. And it's an easy drug to take because you're just popping a capsule now and then, and you're taking it like your Dispirin, and you don't have to have your blood checked any longer, and you don't have to watch what you eat. So those are important, okay. We stopped at atrial fibrillation because I wanted to chat a little bit of atrial fibrillation. Atrial flutter is the cousin of atrial fibrillation, okay? And causes the atria to depolarize at 300 times a minute. So every little one of those P waves you'll find belongs to one big square, which is 300 beats a minute. The AV node prevents all of these from being conducted, otherwise we would all die. I saw a guy recently from the Eastern Cape who was referred to me, where his flutter was conducting at 1:1. So in other words, his top chamber was going at 300 beats a minute, but the AV node allowed everything to come down to the ventricles at 300 beats a minute. And as a consequence, he was passing out with palpitations all the time. And it looked, interestingly enough, just like ventricular tachycardia because it was an SVT with aberration. He was going very quickly, and as a consequence, he had a right bundle. So he had an SVT with pre-existing right bundle, which masqueraded as a ventricular tachycardia. And he certainly, he was shocked, and in the end, we were able to induce typical flutter and get rid of that, and he's been asymptomatic since then. Now, the point that I want to make here in flutter is that the P waves are generally very discernible, okay? They are not difficult to find at all, except if the patient is running at, let's say, 150 beats a minute, and the P wave is then hidden. Okay, so let me just get back to the flutter here, because I just had to digress because of that other slide deck. Apologies, we're almost there. Okay, right, so let's move on. We'll move to AVR. I think it's their turn now. Anyone want to give us an indication what they are seeing on this ECG, please? We have 8 minutes for the tackies and 10 minutes for the braddies, so. I mean, look, it's a lot of information to have to assimilate in one day, but the whole idea is to give you some form of confidence so that you can now sit and look at every ECG yourself, because there's no other way it'll come. So it's not going to all happen today. So start off again with the basic principles. Is the complex broad or is it narrow? It's narrow. What is the rate? I mean, you are equipped with that. 150 beats a minute. Now, let me give you a little pearl of wisdom, okay? If you see a narrow complex tachycardia at 150 beats a minute, especially if it sticks around 150, 148, 149, 151, it's normally atrial flutter with 2-to-1 block, okay? Why? Because we know that the normal atrial flutter circuit runs at 300. So if every second one is allowed by the AV node to go down to the ventricle, then your rate in the heart is going to be 150. So this is what's happening in atrial flutter. You have a macro re-entrance circuit, I'll stand like so, I think, which is running inside of the atria, and that rate is 300. And it's bombarding the AV node at 300, but the AV node says, no, I can't take you so much. Okay, every second one comes through. Okay, fine. So then every second one comes through, and then this thing goes another time, and another time, and it'll let another one down. And another time, and another time, and it's another one down. So essentially the rate down here in the ventricle is 150 beats a minute, all right? But the effective rate in the atria, okay, is double that. It's 300 beats a minute. And that's why when you see a narrow complex tachycardia, 150 beats a minute, just ask yourself, is this not atrial flutter? A re-entrance circuit in the atrium. Okay. And then now you can start looking for like P waves and, okay, what's the QRS? Axis is probably normal. 1 seems to be most positive, could be rightward. If 3 is most positive, it's difficult because you have all of these other funny blips now in the way, you know. Now they talk about the sawtooth pattern of atrial flutter. And I mean, with a little bit of imagination, you can probably see that there is some activity over here. The critical thing that I want you to approach any rhythm disturbance with which is fast is you must ask yourself, what is the duration of the complex? Is it narrow or is it broad? Broad, VT, that's it. You just move on, you know, shock. I'll figure it out afterward. If it's narrow, then you have to ask yourself, regular or irregular? If it's irregular, it's AF. That's it. You manage as AF. 99% of the time, you're going to be right. If it's a regular narrow complex tachycardia, that opens a whole other kind of, you know, then you can call it you know, like our colleagues will do, say, I think the patient's got an SVT. You know what I'm saying? For want of a better term. Is that the SVT, probably? Right. So, what you would do here is you would now say, okay, look, if every one of these is a P wave and every second one is conducted, it's probably atrial flutter with 2-to-1 block. It's a narrow complex tachycardia. And narrow complex tachycardias, which are regular, are either going to be atrial flutter with 2-to-1 block, it's going to be a sinus tachycardia, it's going to be, but sinus tachycardia is not going to stick at 150. Sinus tachycardia 130, 139, then the patient gets a bit more anxious, then they're 170, you know what I'm saying? Oh, your maag en jou nou kom out, 190, flutter, 150. Because that thing is just running in the circuit, okay? So, so that's as far as sinus tachycardia goes. What else can give it to you? You can also have it with the ones which are supposed to be SVTs, which are the ones involving the AV node. And those are your common tachycardias, which is AV-NRT, or the AV-RT, which involves an accessory pathway, and that's where we're coming to now. Okay, so that's quite important to know. So atrial flutter, clue, look for a rate of 150 beats per minute. I'm happy if you call me and say, look, see here, Raz, I have a narrow complex tachycardia at 150 beats a minute. I don't know what this is, but it's not coming down. I think it's a flutter, I can't see P waves clearly, etc. Anything that you can do perhaps to help you see P waves in somebody with flutter where you don't know what to do. Slow it down, yeah. Slow it down. How would you slow it down? Yeah, I think that's the way to go. You go carotid massage. Listen for the bruit, do carotid massage. Because when you do that, often all of a sudden you have AV block. So what happens is carotid massage affects the AV node. Okay? So you're doing the carotid massage. Oh, oopsie, carotid massage over here. You're applying a bit of stimulation. This affects the AV node. The AV node becomes very effective, and all of a sudden he says, every second one come through, no chance. Every fifth one come through. And then you see, PPPP complex, PPPP complex, and then you can make the diagnosis. So for narrow complex tachycardias, as a rule, if you don't know what it is, try a little bit of carotid sinus massage. It goes a long way. It goes a long way. Because if it's an AV node-dependent tachycardia, the chances are you're going to terminate the tachycardia in any case. And what harm are you doing to the patient? Yeah, don't go and, you know, some people are very aggressive. You know what I'm saying? You get there, their hand is halfway down the patient's throat already, you know, and I'm trying to push the eyeballs out of the back of the head and, you know, drowning someone in a cold bath. I mean, it's not necessary for all of that, okay? A lot of it is common sense. You know, a little bit of carotid sinus massage, that will suffice. Any case, poor people standing there, blowing up blood pressure cuffs and so on, they're going into orbit already. It's the, look, you do what you can, do what you must do, all right? But carotid sinus massage or vagal maneuvers, which is what you were trying to say now, are the things that you are going to do. And I'm kidding. You need to do what you need to do, obviously, to try to help the patient. Often it will terminate it, you know, often it won't. The clue is that it works on the AV node. So things which must pass the AV node, like AV-NRT, which is in the AV node, or an AV-RT circuit, we may as well talk about that now. AV-NRT is a circuit where you have a slow and a fast pathway happening within the AV node. So carotid sinus massage or adenosine normally terminates the rhythm disturbance because it works directly on the AV node. An AV-RT is an accessory pathway. Here you've got an accessory pathway over here. Typically, they come in with a narrow complex tachycardia. And then what happens is the signal does the following. The signal does the following. It comes from the top. It goes down the AV node. It goes up the accessory pathway. And the circle continues like that. Another thing that can give you a narrow complex tachycardia. You don't know there's an accessory pathway. You just know it's a narrow complex tachycardia. Try some carotid sinus massage. Because it must pass the AV node, okay? It will sometimes terminate. But flutter runs inside of the atrium. It just happens to be passing its messages down to the ventricle. So when you stimulate the AV node, all that you're doing is you're making the degree of block more. 2-to-1 first, then 3-to-1, then 4-to-1, then you can see the P waves. So do you understand what I mean by the degree of block? That's important. Because you're giving carotid sinus massage, right? And in a typical flutter, you can't see the P waves at 150 a minute because it's hidden in the QRS complex. So you see narrow QRS, narrow QRS, narrow QRS, narrow QRS. Somewhere, maybe over here, there may be something looking like a P. Then you give carotid sinus massage. Then you see the following. You see the QRS, and then you see a couple of P waves. Then you see the QRS, and then you see a couple of P waves. And then normally it continues again. So, but that time when you had AV block, you could identify P waves going at 300 a minute. And then you could say, it was actually flutter with 2-to-1 block. All that you've made it here is 3-to-1 block, 4-to-1 block, to essentially show you where the P waves are sitting. All right. So these rhythm disturbances are probably a little bit more complex, but they're not difficult to see or to understand. If you stick with the basic principles, a narrow complex tachycardia can only be sinus tachycardia. It can only be flutter with 2-to-1 block. It can only be one of those two that I've mentioned, an AV NRT, which is a feedback loop inside of the AV node. Or alternatively, it can only be an AV RT, which is utilizing an accessory pathway. All right, fine. So, excellent. I think I've walked all the way here without that thing now. Okay, so that's flutter. Now, when you see it like this, in other words, when you've slowed it down, you've given a beta blocker, you've given adenosine, you've given calcium blocker, you've given digoxin. Yeah, well, then it's not such a difficult diagnosis to make anymore, is it? Because now you can clearly see that the P waves are there, they are discrete, they have a sawtooth pattern, and they are going at exactly the same cycle length. I can see the P wave there, I draw a line down here, I can see the P wave there, I can see the P wave there, I can see the P wave there. Okay. Are we happy that if a patient comes in with an ECG like this, we can make a diagnosis of atrial flutter? Can we tell the difference between that ECG and that ECG? There is no discrete P wave activity anywhere in the ECG. Okay? Look here. You may think there's a P there, you may think there's a P there, but it's not the same here, and it's not the same here. Now look at the flutter. Look at the difference. You know there's a P wave there. There's a P wave here, there's a P wave here. Okay? Lead 1, in this particular case, we'll probably just need to amp it up. I'm not even sure if it's been connected to the patient properly. But the bottom line is wherever you go, you can duplicate that pattern, that sawtooth pattern of what's called a typical atrial flutter. This is another example. How many P waves are you seeing here? There's a P wave, there's a P wave, probably one caught inside there. So probably there's maybe, again, an atrial flutter with 2-to-1, or it looks actually more like 3-to-1 block. All right. But the QRS is perhaps a little bit on the broad side. But I think we're all happy to see that there are lots of inferior P waves here. And then if you go up, typical flutter, just for those who want to know a little bit more, the inferior P waves are normally negative. They point downward. V1 P waves will always point upward. There's one, there's one, there's one, there's one. Go down, you see it all there. Go down, it's hidden in the tip of that, but it's still there. And in V6, they will always be negative. So that's typical flutter. That's counterclockwise typical flutter. Positive in V1, the P wave. Negative in the inferior leads. Okay? Maybe a little bit out of the scope of the talk, but you may see one because they're actually not that uncommon. So that's atrial fibrillation and that's atrial flutter. And in terms of the SVTs, okay, those are the ones that we just mentioned, which are within the AV node. There are two sorts. So the atrial rhythms, atrial flutter, atrial fibrillation, atrial tachycardia, which is just a spot which is firing away. When you come a bit lower down, supraventricular. They're calling it supraventricular because these ones are not in the atrium and they're not in the ventricle. Okay? They're running between a pathway, for example, and an AV node. Here we have AV NRT, also known as a nodal tachy or a junctional tachy. And then the other one is AV RT, AV node reentrant tachycardia, AV reentrant tachycardia. Involves a feedback circuit of both the AV node and an accessory pathway. So let me draw it for you. Not difficult. Because the ventricles are triggered from the AV node, the QRS will always be narrow. So what happens is you have a signal, and this signal is able to traverse two separate pathways. It goes down to the ventricle via a slow pathway, and it goes up via a fast pathway, and that's the circuit. Down the slow pathway, up the fast pathway. But every time when it is coming down the slow pathway, it also releases a signal down to the ventricles, which will then give you a narrow complex tachycardia without any P waves. This is the commonest SVT you're most likely to see, what used to be called back in the old day a PAT, paroxysmal atrial tachycardia, which is completely incorrect, okay? The term for it nowadays is, it's an SVT, but if you want to be more specific, you say, I see a narrow QRS complex tachycardia. Are we all agreed on that? And I cannot see clear P waves, or maybe there is a little something here. All right, fine, it's not difficult. Then you just tell yourself, I'm seeing something which is narrow, I'm seeing something which is fast. Is it sinus tachycardia? Okay. Is it, and you know sinus tachycardia is going to vary. Is it flutter with block? Give carotid sinus massage. Is it AVNRT? Give carotid sinus massage, you may terminate it. Is it AVRT? Give carotid sinus massage, it may terminate it. So your diagnosis in the end of SVT can be a little bit more specific, okay? In particular because if you think, no, but this is much faster than 150 a minute, for example, it can't be flutter with 2-to-1 block. All right. So you've got a narrow complex tachycardia here, which is regular. Okay, I'm bombarding you with lots of stuff, and it's late in the afternoon and you want tea. But it's important for you to let me know if you're not with me. I mean, don't hesitate. Are we happy about the narrow complex tachycardias? That you can see that it's narrow and that you can see that it's fast. And that it can only be one or two of those SVTs, or atrial flutter with block, or a sinus tachycardia. And sinus tachycardia will vary. Sit there long enough, it will change. 118, 120, 140, 150. So these things, they keep their rhythm. It's very static. If they go off, it's 1 or 2 beats either side, but not more than that. All right? So remember that. Now, the patient had AV-NRT. Adenosine, as you know, is an AV nodal blocker. Okay? So anything passing the AV node normally will be terminated by adenosine. So you give adenosine, and afterward, what do you see? Right. Can I have a comment on this ECG, please? AVL. Is the patient in sinus rhythm? Okay. What is the rate? $48. 148. My apologies, my apologies, my apologies. All right, fine. So it's a sinus tachycardia. Anything else on the ECG? Narrow complex, yeah. So do we think maybe the tachycardia is now over? I don't know, I think so. I think they had the adenosine, they were in SVT, narrow complex tachycardia, no P waves. Gave the adenosine, now I can see P waves. Otherwise, how could I tell the patient was in sinus rhythm? So the tachycardia has been terminated. But it's still tachycardia, but it's sinus tachycardia. Okay? So that's the important thing. This is just the effect after the drug has been given. The drug doesn't only stop the AV node conduction, it also speeds up the sinus node for a few minutes. That's called the second phase effect of adenosine. Often they have tachycardia afterward. All right, so that's the one type of SVT you see, which gives you a narrow complex tachycardia. And normally in that tachycardia, you can't see the P waves because at the same time that that thing is going up to the atrium, it's coming down to the ventricle. It's happening at the same time. This one is a bit different. Here, you have an SVT which is happening, and I just drew it for you now. It's going down the AV node, and therefore it will be narrow complex. And thereafter, it goes up the accessory pathway. And that's how it runs. Okay, down the AV node, up the accessory pathway. But because it involves the AV node, again, if you give adenosine, it may terminate it. It just can't tell you by giving adenosine which of the two it is, right? A feedback loop between the AV node and accessory pathway, usually conduction goes down the AV node, up the pathway. Occasionally the other way, which looks broad and scary. In other words, occasionally this can go down the pathway, up the AV node. If it goes down the pathway, anyone want to tell me what do they think? Will it be broad or narrow? It will be broad. Why? Because it's no longer within the East Purkinje system. See? So now you have another cause for a broad complex tachycardia. And that is what is called antidromic WPW syndrome. So those are the only 3 causes of broad complex tachycardia you'll ever get. A patient's got ventricular tachycardia. A patient has had already a left bundle and now they're getting something from the top. So in other words, it's a supraventricular tachycardia with pre-existing bundle, or alternatively, an antidromic WPW where all of a sudden the signal comes directly down, not involving the East Purkinje system, from the atrium is jumping across the pathway directly onto the ventricle. There are only 3 causes of a broad complex tachycardia. So listen, if you see a narrow complex tachycardia and it's regular, you've got 5 things you can call it, you can never go wrong. Plus the treatment for all, carotid sinus massage in the meantime. If you're really stuck, give a beta blocker. It's safe, it's the only one with a neutral mortality. The only patients I do not give beta blockers to are people who have been ventilated for asthma and people who are using huge doses of corticosteroids every day. Those are the only people who cannot tolerate a cardioselective beta blocker. Take my word for it. Steroid-dependent asthmatics, not a little bit of They handle the beta blocker just fine. All right? Occasionally the other way, which looks broad and scary, and then here you must rely on seeing an accessory pathway. So the whole question of accessory pathway, obviously now we come to the talk of WPW syndrome. Okay, first, we're going to AVR now. What does AVR see on this ECG? Is the patient in sinus rhythm? You don't know. You can't see. Okay, then you say, but I can't see. Right? Do you see QRSs at least? Right. And they are narrow, thank you. And what rate are they going at? 150? Yeah, I reckon they're 150. So, a narrow complex tachycardia, 150 a minute, what's your diagnosis? Flutter with 2 to 1 block. No one can argue with that. Nobody in the world can argue with that if you tell them that's the diagnosis, okay? Right. I want to point little something out to you here. Now, EP people, we have amazing powers of hallucination. That's the only way we can get through our job. You must hallucinate these little things that you see. But in any case, you would agree that it does appear to be a little like, well, for the want of a better term, nipple-like structure, okay, on top of the V1 there, okay? And that nipple-like structure is transferred all the way down in that lead and in that lead as well. And then I go back here and I see, man, there's something in there, and there's something in there, and there's something in there. But maybe I'm just imagining myself. So let me see what happens here. I can draw it all the way down there. There's a blip there. There's a blip. So the question is, am I not seeing also some P waves? I don't know which way the P wave is going. I don't know if the P wave is causing the QRS or the QRS causing the P wave, but I think I may see a P wave. Now, when you have that situation, when you can see the P wave, you're probably more likely dealing with an accessory pathway, okay? And the answer is simple. You see, in this particular setting, the signal has to go down the AV node and then has to go and find the accessory pathway to get back to the left atrium. There is time involved. The time involved allows for the P wave to be seen, okay? In this particular setting, you can't really, okay, this is rubbish, this initial bits of the ECG. Let's look here, okay? You can maybe say, well, that's a little something there, possibly, a tiny little P wave. You can probably make a case for that. But a P wave will never conduct so quickly to the QRS opposite. It's impossible. So this P wave in this case is probably because of the QRS rather than a cause of the QRS. But the bottom line that I want to make is that the anatomic circles are different. Here, this guy doesn't have to go and find another circle. Oh, there you are, I must get up to the atrium. This is happening sequentially. This thing is going down the slow pathway, up the fast pathway. This is how it's running. But as it's doing that, as it's coming down here, it's going up the fast pathway. So the atria and the ventricles are being activated sequentially, not serially. They're getting the activation at the same time. So the P wave is often hidden inside of the QRS complex because you're making a V and a P at the same time. So you're doing that so you can't see the P. So if you can't see the P, then you can probably say, well, doc, got a narrow complex tachycardia over here, can't see the P, probably AVNRT. But in the end, no one knows until we've done the EP study. No one knows until we've done it. Okay, but I'm just giving you little clues that here, the mere fact that a P wave became visible probably means that that you're leaning toward an accessory pathway. Okay. Any rate, so here you have your patient, and you've given the patient adenosine, and now what do you see? Which actually it's AVL's turn. Is the patient in sinus rhythm? I think tonight you're going to be lying in bed and the patient, yes, the patient is in sinus rhythm. A delta wave, woo, a delta wave in V4. Now we're talking. Okay, let's start with, is the patient in sinus rhythm? Okay, what's the rate? Where's our calculator over here? 90. Right, fine. So sinus tachycardia per definition, more than 90. Less than 60, more than 90. 90 or more. Right. PR interval. PR interval. Because all along until now, the PR interval wasn't important. We were looking at the PR, we were looking at the PR. Now I want to know what's going on here now. PR interval. You have the impression in the anterior chest leads here that the PR interval is very short. Almost as if the P is joined up with the QRS complex. You also have the impression that the QRS complex has got a very slurred upstroke to it. The term for that is a delta wave. This is a patient with WPW syndrome. So this confirms the fact that that was probably an underlying accessory pathway that found its way toward the P. Because now in sinus rhythm, you can see the delta wave. And the term for it is ventricular pre-excitation. What does ventricular pre-excitation mean? It's a very, very, very simple complex. Very, 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 very simple to understand. Here's your sinus node. Here's your AV node. You're going from here to here, right ventricle, left ventricle. Here you have an accessory pathway. This here, the AV node, the UK Border Patrol, whatever you want to call it, the speedkop, it has the ability to filter things and slow it down. Okay? You've seen that with Wenkebach. Longer, longer, okay, you're not coming through. You've seen it with complete heart block. No one's coming through, you know. It's got the ability to do it. The term for it, it can decrement, okay? So what happens is when you're seeing this, a delta wave on the ECG, all right, you see there's very little time between the P and the QRS. What's happening here? Normally, if it comes down here and it comes here, I should have some form of P and then R delay before the QRS complex, because that's delaying it. But in this particular situation, that extra channel over here does not have the same powers of braking as the filter, which means that at the same time that it's throwing one down here, the signal is also traveling down the accessory pathway potential, which doesn't have a brake, and it starts to pre-excite this muscle on this side already. In other words, the muscle is being activated while the AV node is still being stimulated. And that is why it will appear to be broad, because it's no longer using the AV node conduction system. It's using an accessory pathway to get to the muscle. So that bit of muscle that it's getting to very early there, and it's getting to it much earlier because of the fact that you don't see any PR prolongation, is called the delta wave. And it's got a very, very typical slurred upstroke. You see it in V1, V2, V3. So this lady's SVT was in fact caused by an accessory pathway. Okay? And you can only say now, well, she's had palpitations, and I can see a manifest pre-excitation, delta wave on the ECG. Now you can say this patient has got the WPW syndrome. You have to have both of those components present. Okay? Right, so this is to end the session, and it's relatively easy. You have your broad complex tachycardias. I've told you about the differential diagnosis. Treat all as VT, it means urgent cardioversion. The EP doctors can decide afterwards if it was anything otherwise than VT. And normally they'll be guessing in any case. Eh? If it's broad, if it's fast, if it's regular, it's ventricular tachycardia. Right, okay. AVR, diagnosis please. I can't hear? Okay. AVL, what's the diagnosis please? Thank you. That sounded a little bit more, you know, robust. It's like, you know, there was a bit more confidence in that. I mean, you know, it's rapid, it's broad, it's fast. it's regular. I mean, it can't be anything else. Don't allow your mind to wander from this ECG because you will lose the patient if you do that. That's what this last bits are about. I'm very passionate about this because, unfortunately, we do see problems related to this. Okay, AVR, what is the diagnosis? VT or ventricular tachycardia. Broad, fast, regular VT. Right. Okay, AVL, what is the diagnosis? VT. VT, it's like AF. You're not allowed to leave this room today if you can't diagnose AF. We will have supper, we will have breakfast. You're not allowed to leave this room if you can't call a broad, rapid, complex tachycardia VT. It's unacceptable. Those are the two things which I must equip you with, which you must leave with. Okay, so a little bit of additional information. In VT, a right bundle morphology is common. It's right bundle because it's broad. You looked at V1, it was upright, it was nice right bundle. And right bundle normally implies that the delay is on the side, okay, of where the right bundle is, okay? And it means that it's normally of left ventricular origin. So if you see a right bundle, it normally tells you that the VT is on the left-hand side. That's actually how you want to know. So you see VT, and it's got a left bundle, you say it's probably on the right-hand side. Okay, if you don't know that it's VT, but it obviously does this, you have a broad run, and then a narrow QRS complex, and obviously you can say, okay, that was not an SVT, that was probably ventricular tachycardia, which has now gone into sinus rhythm. How to treat the patients? You shock them if they're unconscious, and if they're conscious, then you put them to sleep and you shock them. But you will shock them, okay? A stable patient can rapidly become unstable. Don't put patients onto intravenous amiodarone and intravenous lignocaine and you name it, okay? You have no leg to stand on, medico-legally, if that's what you've done. A stable patient can rapidly become unstable if you hit them with a chemical hammer, like IV amio, or you want to give, I don't even want to mention verapamil and those things, etc. You can make the patient very, very, very unstable, okay? And you cannot come back from that if you've made that bad call, okay? This is a very special form of VT, which is called torsade de Poix, and it's normally associated with electrolyte disturbances, or alternatively, the long QT syndrome. It looks a lot like ventricular fibrillation, of course, but the only difference is in torsade, the patient will be sitting and chatting to you while they're having it. VF, a little bit different, okay? Fine. So that's different. We see that ECG, obviously, you can tell that the RR interval is very chaotic. It's clearly an ECG of someone who's gone into ventricular fibrillation. Right. Take a guess what? What happens if you have don't even look. What happens if you have a broad complex tachycardia and it's irregular? What is the diagnosis? What's the diagnosis? Atrial fibrillation. Okay, right. This is usually AF with a bundle branch block, okay? Because, I mean, a VT is going to be irregular. So if it's irregular, it's AF, and then it's broad because of the fact that there was a pre-existing bundle. Any rhythm which is irregularly irregular is usually atrial fibrillation. Okay, right. Let's finish off. What's the rhythm? Yeah, I mean, it's deliberately designed that way. It's deliberately designed that way. What's the rhythm? It's irregularly irregular, so it must be. Okay, and why is it broad? Because there had to be a pre-existing bundle branch block. What kind of bundle branch is it? Excuse me? Is it broad? Which lead do you look at? What does V1 do? If it's down, it's? This is AF with left bundle branch block. End of the story, okay? There's no other way to look at it. Right, what is the rhythm? Okay, I mean, listen, guys, by now we know what the irregular rhythm is. Call it by its name, please. Thank you, it's atrial fibrillation. And atrial fibrillation with? The QRS appears to be broad down here, huh? And certainly it looks like there is a bit of an RSR pattern now. Is V1 pointing up or down? If it's pointing up, it must be? Right, this is AF with? Right bundle branch block. Excellent. What is the rhythm? That's not the same. Sorry, where is it? That one, yeah? Well, that's not the same, that's not the same, that's not the same, that's not the same. Can't really see PLP, or maybe a little something in there, but I can't see something in there. Okay, so it's AF. Why is it broad? Bundle branch block. What kind of bundle branch block is it? A right bundle branch block. Okay, okay. Right. Why are they saying something else in addition? I mean, look, we were just looking at the rate now, and we didn't go through the whole ECG. But someone want to tell us about the axis. The axis is leftward. Why? V1 is your most positive. If V1 is your most positive and lead 2 is predominantly negative, the axis is? A left axis deviation equals left anterior vesicular block. And you have already got a right bundle branch block, so left anterior vesicular block plus right bundle branch block equals bivesicular block. Exactly. Okay, so this is actually AF with a bivesicular block. Fine. Klompie goedes, né? Right. Are we ready for tea, Tracy? Thank you very much.